Okay, I think we'll get started. Good morning and welcome to Palliative Care Friday Chalk Talk. Today we have Dr. Paige Scholler to talk to us about what matters most at Crossroads in geriatrics and palliative care. Dr. Scholler is a hospice and palliative medicine fellow with Advocate Aurora Healthcare. She is from Omaha, Nebraska, and completed medical school at the University of Nebraska Medical Center. She completed a combined residency fellowship program in internal medicine and geriatrics with the Medical College of Wisconsin in Milwaukee. And after completion of her hospice and palliative medicine fellowship, she hopes to stay in the Midwest and practice a hybrid of outpatient internal medicine, geriatrics, palliative care, and nursing home care. Thank you, Dr. Scholler, for being with us today. And I have your slides up, so take it away.
Sounds great. Thank you so much for the very kind introduction. All right, next slide, please. Oops. Oh, perfect. Okay. So before I get started, just to provide an outline of what I'll be talking about today, the first thing I'd like to talk about is to introduce and review the 5 M's of geriatrics. Then after that, I'd like to talk about some of my own reflections from my first fellowship with regards to what matters the most in geriatrics. And then after that, I'd like to provide a little bit of a literature review when I was looking into what matters the most in geriatrics, and especially what matters the most in the trajectory of chronic illness and at end of life. And then lastly, to talk about future directions in terms of how we have these goals of care conversations with patients, and especially considering what matters most. Next slide, please. So with the 5 M's of geriatrics, just to give an overview of this piece, this defines the core competencies of effective care for medically complex older adults. And it's really, there to help to define those core competencies in a really memorable way for clinicians and patients. And this third bullet was actually something I wasn't really aware of until I was doing more research on the 5 M's of geriatrics. But this is sometimes referred to as the geriatrician's salute or the high five to geriatrics. And I think you'll be able to see visually why that is the case in the next couple of slides here. And so the 5 M's of geriatrics, this was first presented in April of 2017 by Dr. Mary Tanetti at the Canadian Geriatric Society annual meeting in Toronto. And this is really a summation of a couple of different efforts, because there was the 4 M's originally, which was mind, mobility, medications, and multi-complexity in Ottawa, Canada. And then there were some additional efforts in the U.S. through the Age-Friendly Health System Initiative about 5 or 6 years ago. Next slide, please. And so again, to give that visual, looking at the geriatric 5 M's, I think we can all kind of see pretty quickly then with how the 5 M's are represented with these hands. So kind of with that salute, the high five, right? Just the holding hands, so to speak. And so to just review these 5 M's very briefly. So with multi-complexity, we know that a lot of our older adults have a lot of different comorbidities, a lot of different health conditions. And then with the mind, mentation, we know that although it's not a normal part of aging, we know that dementia, cognitive impairment is a condition that's very common in our older adult population. The next piece is with mobility. We know that a lot of our older adults have changes in their gait and ambulation. They use assistive devices like walkers, canes, those types of things. And just that mobility is so important in general. One of my geriatric faculty that I worked with during my first fellowship had talked about, if you don't use it, you lose it. And so just the importance of being able to be ambulatory. Medications, a huge part of working with our older adults. A lot of our older patients are on so many medications, which increases the risk for polypharmacy and adverse events. And so always important to make sure that our patients are taking appropriately prescribed medications and to attempt to deprescribe when possible. And then certainly what matters most, which is going to be the focus of my talk today, and really just delving into what the patient's goals are. Again, what matters most to them. Next slide. And so just to reflect a bit on what matters most from what I learned during my fellowship. And this was kind of a unique experience for me in the sense that that with my combined internal medicine, combined internal medicine geriatrics training, that I had this geriatrics exposure through all 4 years of my training. And so I really had that exposure to the 5 M's pretty much every year of my training. But I remember I really started to make use of this question, what matters most, especially during my fellowship when I was doing consults over at Freighted Hospital. And one of my attendings loved to ask this question, to every patient that we saw in consults together. And initially, admittedly, I thought, it sounded kind of cheesy in the moment to ask that. But then as I started seeing more patients on consults, and I remember, especially before I would staff with my attending, I would start asking this question. And admittedly, initially, it was more I felt like I was asking it just to appease my attending, to make sure that when I was asked about, when I was staffing with my attending, I knew that I was going to get asked, did you ask what matters most? But it wasn't long before I started to ask that question that I got a lot of really interesting responses that are detailed below here. Just a variety of themes in patient responses. And so, for instance, talking about things like being safe, being independent, being able to interact meaningfully with family, with friends, being comfortable, not suffering, faith, religious beliefs. And I really started to realize that asking this question, not only did it provide a lot of different themes, to work with in terms of providing that really patient-centered care. It also, for a lot of our patients who might not be able to advocate for themselves, who have cognitive impairment, who have dementia, that it really helps us to be a better advocate for them with their care. Next slide, please. And so as I look through the geriatrics literature, one study that I found that was particularly interesting this was done in the UK in February earlier this year. And this was a study that looked at frail older adults. And the study was performed about a month after they had had an acute hospital stay. And so their healthcare outcome goals were explored in semi-structured interviews that lasted anywhere from 20 to 80 minutes. So quite a variation in terms of the time. And the patients were either interviewed by themselves or in the presence of a caregiver or a loved one. Some of these patients had dementia. Some of them were cognitively intact. And it was a lot of open-ended questions that talked about, what their worries were about going to the hospital, their hopes for treatment from the medical team, how is their condition explained, and what had changed during their ER course. When I looked at the questions that were asked, there wasn't anything specifically that used the words "what matters most," but certainly a lot of different questions that really focused on the worries, the hopes, the fears. Next slide, please. So I know that this is a busy slide and I won't go through everything verbatim, but in looking at this study, there were certainly a lot of themes that were represented in terms of patient autonomy and patient function. And so the things that patients talked about a lot with these interview questions, things that were really important to them with information, making sure that they got the information that they desired the most, being able to receive a treatment plan, understand the problem severity. Security was definitely a big one, being able to get back home, feeling safe where they were at, feeling safe with their health issues. Control, obviously, another really important one, being able to make their own decisions. And then with physical functioning, certainly another very important thing, being able to care for themselves, do the things that they enjoy, being able to get up and get around, and having really, really good support. And then psychosocially, being able to care for their loved ones, being able to think clearly, keeping in touch with people, and not being a burden on others. All right, next slide, please. And so now, as I'm in my fellowship for hospice and palliative care, one thing I've noticed, and especially when I did palliative rotations during my geriatrics fellowship, and then continuing those here with Aurora, one thing I've noticed is that many goals of care conversations start inpatient, and I think as we've all noticed in our work. And so there's really no official consensus yet on how to elicit these goals. Certainly many different styles of how to talk with patients, and there's no one style that's better than one other. We all have our own different styles of how we ask these questions. I think one thing, though, that I've noticed in terms of how we talk about these goals, though, there's kind of two different kind of frames of mind. There's the intervention-based, and then there's the outcome-based. And oftentimes what we see, if I'm looking at a goals of care note in the medical record, what I often see that's being discussed is, what does the patient want in terms of interventions? Do they want CPR? Do they want intubation? And what we often see on those notes too is, that's defined as what their goals of care are in terms of, again, those interventions. But then kind of pushing it a bit beyond, just the interventions. The other really important piece is to discuss the functional outcomes of some of those interventions. And in doing so, we really ask for what the patient values, what matters most to them, because those patient values will then help to inform those clinical decisions. And I think oftentimes give us a much richer explanation, much richer background of how we can make sure that we're giving recommendations that align with what the patient values. Next slide, please. So this is again a very hypothetical case that I looked at from one of the journal articles that I reviewed, which again mentioned it as a hypothetical case. So this is Mrs. G. She has a past medical history as noted here, and she has had some unintended weight loss, slowed gait, and more fatigue recently. So using approach number 1 for a goals of care discussion, this would be, again, asking what interventions Mrs. G would or wouldn't want, essentially establishing a code status. Next slide, please. So same patient, same case, but now we approach the goals of care discussion from a different angle. Instead of asking Mrs. G, would you want CPR? Would you want to be intubated? We ask Mrs. G, what matters the most to you? She tells us, sorry, I can't talk. She says, I want to be able to walk to my mailbox independently. So from that statement, then we can start to think about counseling, about limiting aggressive interventions, because of the concern that, yes, well, it would extend her life. That would be potentially at the expense of precipitating functional decline. Next slide, please. And so in reviewing some of the hospice and palliative care literature, there was one study that I found that was interesting. This was some time ago, back in 2006. This was a Canadian study that was looking at the goals of hospitalized patients with advanced cancer. And they used a 28-question survey that used differing degrees of importance, from not at all important to extremely important. Next slide. And so in terms of what was extremely important for patients, the most important for patients was having trust in their providers, not prolonging suffering, having direct and honest communication about their chronic illness, and having closure at the end of life, being able to say goodbye. Interestingly, what was not extremely important for patients, but in parentheses there, as I've noted, still very important, was having a sense of control. Or having help with difficult medical decisions, and then being able to contribute to others. I think what was interesting about the piece with not extremely important for patients, especially with our role as palliative care providers, is that we get consulted so much in these goals of care discussions with helping with difficult medical decisions, and how much patients and families value our role in that piece of their care when they're in the hospital, or if it's on the outpatient side of things. So again, that was a bit surprising to me. Still very important, just I thought it would be very, very important, or extremely important. So, and again, that sense of control, I think a lot of patients talk about, especially being in the hospital, that they feel less control just with everything that's been going on, and they want to be able to regain that sense of control with being able to navigate the future, what lies ahead. Next slide. So I think in terms of, future directions, and as I've thought about things with my practice, and as I am merging geriatrics and palliative care, I think it goes without saying that that we all need to make sure that we're not only talking about interventions that a patient would or wouldn't want, and really focusing on basing it on values, what their values are, what matters the most to them. Because I think when we approach it from that standpoint of what matters most, what their values are, we again get a much richer discussion that really, I think, starts to incorporate more of their their medical background, the psychosocial background, their fears, their hopes, their worries, all those things. And I think it just gives us a much richer picture than of how we can counsel them and really have a better understanding of their goals. I think certainly what matters most is not the only question that should be asked. But in my experience so far, I think this has been a very, very helpful question to have in my toolkit. Again, as both a geriatrician and as a palliative care provider as well, this is just very helpful to be able to elicit those patient values. I think importantly too, that this question isn't, even though it's within the 5 M's of geriatrics, what matters most is not a question that's just for older medically complex adults. I think this is truly applicable to anyone, certainly younger than 65. And I think importantly, and as we've all seen with patients who have chronic illnesses, life-limiting illnesses, that the goals evolve as our health evolves. And so I think being able to revisit goals, and in terms of asking what matters most, I think it's just an interesting piece to think about, in the sense of when we talk about what matters most now and what matters most to us 5, 10, 15 years from now, and seeing how those priorities evolve and as they change. I think that's again just an important point to keep in mind. Next slide. So I think this will be a really good point of interaction and talking about in the comments, if you feel comfortable doing so. I would like to just hear from anybody in the chat box, or if anybody wants to, comment, unmute themselves at any point. It would just be really interesting to find out what matters the most to you. It doesn't have to be one, just one particular thing. It can be a variety of things. But I think it would be really interesting to hear from everybody in the chat on this talk today. What matters the most to you? Okay. The next slide.
What are your thoughts about the role of the patient portal to reach out to the population that we take care of, to capture some of the advanced care practice planning versus being in clinic with them?
I'm just thinking a bit. I think certainly, one thought, with the shortage of providers who are trained or willing to review advanced care planning, I think the willing piece, I think, is certainly something to think about, because I think there can still be such hesitation on the provider end to bring up these discussions. And I think more and more, I feel like patients want to talk about these things. They want to talk about these things in clinic or, in the hospital. But I think sometimes there's hesitation on the side of the provider to have these, to have these discussions. And sometimes because I think they're afraid that they think that the patient or their family might be afraid to have these discussions, or there's hesitancy on the part of the patient to have those discussions when in fact it's the complete opposite. So I think it's really important for providers to approach it from that standpoint of overcoming that hesitancy on their end, to then have these discussions with patients and to know that patients are probably more open than we might assume to having these conversations.
Martin, did you have a question or a comment?
Yeah, thanks for the presentation page. The very last bullet point, I think you said, goals can change, goals can evolve. And I think one thing that you will see more and more of your fellowship is how quickly those goals can change. They can change overnight here in the hospital as clinical conditions change. And it's important that we give patients and family members, and even reminders to the medical team, that there needs to be room for what matters most to be able to change. And I think of the analogy of the high diving board, right? We are all hanging out in the pool, looking up at the high diving board, and we imagine how we might feel when we are up there, but it is only hypothetical at that point. And until you climb all the way up the stairs and your toes are curled over the edge and you're looking down, and once you jump, that's it, you have jumped. Sometimes when people are up there, what matters most and what they want to do changes, and that is okay. And to give people room for that to potentially change, I think is very important.
Mm-hmm.
I agree. And I think getting back to Thomas's question or comment, that's the challenge in the outpatient setting, is that if the focus is on a one and done conversation, okay, I've accomplished that, I've checked it off the list, that often is just the beginning of the conversation. So I think we need to be aware of that and train people as such that are willing to have those conversations. Well, Paige, I don't know if you're seeing the chat, but there's varying responses to what matters most. So I think that it kind of illustrates your point, right? That it's really variable by person. So if there are no further comments, we can adjourn for the day. Thank you, Dr. Scholler, for a great presentation.
Mm-hmm. Thank you so much.